This morning I was reading some of the events that has been happening in terms of the health sector on the continent. In Nigeria, for example, we've lost 16,000 doctors since COVID. These are people that have migrated from Nigeria, mostly to UK, but some, of course, to Canada and the USA. So I was checking the latest stats. The doctor to patient ratio in Nigeria today is one doctor for about 9,000 patients. Just oppose that with the fact that the World Health Organization recommends one doctor to 600 patients. Nigeria is not even unique in this. So if you look at South Africa, it's about one doctor to 3,000 patients. If you look at Kenya, one doctor to 5,000 patients. So you have relatively very, in terms of the ratio of doctor to patient, is in a very, very terrible situation. Now, this is exciting. This is why the idea of AI complementing or AI supporting, it's actually an interesting one, of course, globally, but specifically for us on the continent. And so that's part of the reason why I'm really, really super excited about this topic. Like I said earlier on, Lumbani is actually stuck in a meeting in their World Health Organization meeting. Unfortunately, he is actually the coordinator of the meeting, so he can't excuse himself. The hope is that he's able to join before the end of this meeting. So their meeting was rescheduled for some technical reasons. Anyway, so my name is Kenneth. Let me just introduce myself, then I'll allow our distinguished panelists to introduce themselves. My name is Kenneth, and I run Mozisha. We are building talent infrastructure for the AI economy in Africa. Today, like you guys have said earlier on, we're really focusing on this subject of AI in health. And I will really want to yield the floor to the panelists to actually really tell me a bit about themselves, maybe a little bit background of where they came from and what led to what they are currently doing. Of course, they still have to tell us a bit about what they are currently doing. Let me start with someone from the west of Africa, Faith.
Hello everyone, my name is Emora Faith Ashikola. I'm a perioperative nurse based in Lagos, Nigeria. So I work hands-on with the Da Vinci robotic system for urologic cases. So we mainly do radical and simple prostatectomy, robotic assisted radical and simple prostatectomy. We do transurethral resection of the prostate, which is called TURP. We do Urolift. Then we also do procedures such as flexible cystoscopy, as well as MRI fusion biopsy. So we also work with other advanced laparoscopic technologies in the OR. And my work mainly focuses on ensuring safe surgical workflow, maintaining the sterility standard of the instrument, and bridging the gap between the use of the robotic system and in real life patient care. So that's okay. So what led me to doing that, right?
Yeah.
What led me to working as a robotic nurse was we had an introduction to where I'm currently working now. We had an introduction to the place while I was in school. So after school, I applied to them that I would like to learn more on what it is exactly that they are doing, and that was how I ended up here.
Awesome.
Thank you very much.
So fascinating. Thank you so much for that. Next on the line, let us welcome Maureen.
Good afternoon, everyone. Good morning, evening, wherever you're connected from. And thank you so much, Dr. Kenneth, for this privilege and honor. So my name is Maureen Etuket Ruswa. I've not added the doctor there. And biomedical engineer by profession, and currently leading a biomedical engineering company based in Uganda. So I'm Ugandan, but based in Cape Town. Yeah, doing my postdoc right now at University of Cape Town. And I currently run two companies. One is PAMSI Devices, and we are a biomedical engineering company focused on developing biomedical engineering interventions for especially the maternal healthcare space as well as the emergency healthcare space. And we have one device which is almost getting into the market, and I'm very excited about that. And also the company in Cape Town is Botec, and I'm the CEO. And we're just focused on education technologies, especially for the low resource schools, teachers and students and the like. And what led me here, especially today's discussion talking about healthcare. So I think I just, back in the day during my high school, I wanted to be in the intersection between engineering and medicine. So I ended up doing biomedical engineering. And afterwards, just immediately I got inspired to just solve problems as opposed to just, you know, interacting with imported devices, which makes up most of our healthcare systems. So my interest was just how can we, I identified lots of challenges with the imported devices. So now my mindset is how can we come up with context appropriate devices for our setting. So that led me to, I was working in a company called Principality. Later on, I started PAMSI, and the maternal healthcare space. Part of the projects I've been engaged in are in the maternal ward, and just seeing some of the women dying because of postpartum hemorrhage. And I'm like, no, I'm a solution here. I can't accept this, not on my watch. So that's how PAMSI started. And we're currently developing an under-buttock drip for real-time estimation of blood lost after delivery, and we are almost in the market. Thank you
Wow.
so much, Kenny. Over to you.
Awesome. Thank you so much for that introduction. Now, the last but not the least, we have Chidi Akusobi. Over to you.
Yes. Good morning, everybody. It's morning here in California, so morning to those folks here. And thank you to Mozisha and to Dr. Kenneth for inviting us and having this conversation. I'm very excited. So my name is Chidi Akusobi. I was born in Nigeria and immigrated to the United States at the age of 2 to New York City. And I'm currently a physician scientist. I did my MD PhD at Harvard Medical School, where my PhD was in basic science, studying tuberculosis and other related organisms, and then did my internal medicine residency training at Massachusetts General Hospital in Boston. And it was during this time, around 2022 to 2025, where AI really became, I would say, hot and entered the sphere of so many different industries. And so while I was very interested and still interested in basic science, I saw a lot of opportunity for the intersection of AI in clinical medicine. And so that my interest in AI and healthcare grew during that residency experience. And because of that, I actually went to Stanford. So currently at Stanford now, doing dual fellowships in infectious disease and clinical informatics. And clinical informatics is a specialty in medicine that sort of houses a lot of the AI work that's being done. And my interests are at the intersection of infectious disease and clinical informatics. And so how do we use AI to make the work that infectious disease doctors do more efficient, more equitable, et cetera. And so how I got into this field, I sort of talked about it, you know, the way that ChatGPT and other tools entered the public sphere and then in turn in medicine. But I've always been someone interested in technology and applying new technology to problems that we have as humanity. And for me, medicine is one of the ones that touches on everybody. And so it's been a fun ride to see how these tools are being very quickly incorporated into medical care. And so currently at Stanford, I'm involved in various projects to build AI tools for clinical workflows, as well as implementing and studying them as well.
Fantastic. Awesome. Thank you, guys. One question that I should have asked is maybe if you guys could just tell us one other thing you are interested in, but of course we can move on. I wanted to ask that because for Chidi, of course, even though he's functioning in the medical domain, he's also very, very, could I use the word fanatical about space and the things of that nature. To the point that I think he did his internship at NASA, right? If I'm not mistaken.
That's right.
Okay, awesome. Once again, thank you, everyone. This is really, really a very critical conversation for us to have. Let's start with an honest picture of where things are today, right? We're not talking about the headlines, how AI is going to change the world, not the conference keynotes and the rest. What is actually happening based on your own vantage point of work where you are working? What is currently happening in terms of AI within the clinical workflow as of now? Where is it working, and where is it still much of a promise than a reality? Now I'm going to start with Chidi. Chidi, from your work on chat, I think EHR is electronic
health record.
Yeah, electronic health record. Now, what are the clinical settings where AI is genuinely adding value versus where it is still aspirational?
Yeah, that's a great question. And so I'll say that AI has been incorporated into healthcare at astonishing speeds. I think it's probably the same for other industries, but I can only speak to medicine. And so I was looking at the statistic in 2023, about 38% of physicians reported using AI. By 2024, that number has jumped up to 66%. And now if you were to ask survey physicians in 2026, I would say that number is probably closer to above 90%. And so in just 4 to 5 years, the use of AI tools in clinical practice has skyrocketed. And what are the pillars that we're actually seeing AI being used in ways that are effective? There are a couple. So the first is in scribes and documentation. A lot of the work that physicians do is actually based on a computer, at least here in the West, where you are using electronic health records to write notes, to put in orders, to communicate with patients. And that work can be quite overwhelming. And so there have been a lot of tools that have come out that allow AI tools that allow physicians to basically offset some of that documentation and clerical work to AI. So that's one. The second domain that we see a lot of AI tools being used in medicine is in imaging. And this is actually one of the first use cases where we generate so much data in medicine from images, chest x-rays, scans of the chest, scans of the belly. And we use those images to do things like detect disease, to identify if someone has cancer or not, et cetera. And so AI has been implemented into a lot of clinical workflows for chest x-rays, for CT scans, for breast mammograms, to basically identify lesions faster, and also to just identify them more quickly. And so that's another realm that you use AI, that AI is being used. I would say the third, before I talk about chat EHR, is with large language models. And this kind of correlates with the way that the public is using ChatGPT, is using cloud. People just are asking these tools questions and getting answers that are quite complex pretty quickly. We have the same in medicine. You can use ChatGPT in cloud, but there are actually specific large language models for medicine that doctors here are using now almost ubiquitously. And those two are open evidence. And so that is a LLM that's specifically designed for medical knowledge and medical information. And that's because it's tied into medical journals like the New England Journal of Medicine, like JAMA, and other highly respected medical journals. And so you know that the questions that you're asking is being answered with citations to established medical journals. And that's really important because in medicine, the cost of being wrong or hallucinating an answer can be someone's life. And then there's DocsGPT, which is another large language model that people use to help write notes, to help write prior authorizations to get insurance to cover medications that they ordinarily wouldn't. And so you're using, every day, I would say doctors in the field are using these tools to augment their work. And the final thing I'll say is Stanford is one of the leading hospitals when it comes to incorporating AI into clinical workflow. And it makes sense. Stanford is in the San Francisco Bay Area. There's a lot of tech in this. Silicon Valley is here. And so as a hospital, Silicon Valley and medicine really finds its intersection at a place like Stanford. Chat EHR is a large language model that Stanford has built that's embedded into the electronic health record. So you can imagine having ChatGPT within a patient's chart. And for doctors and other healthcare providers, that's huge. That allows us to actually use natural language to ask questions of a patient's chart instead of in the past having to click through a bunch of like documents and click through a bunch of folders, etc. We can now use like a ChatGPT in an electronic health record and ask the question, when did this patient present with X disease? Or when was the last time this patient got X medication? And it comes up with your answer. It can also do things like do a full-on chart review for you. So you can quickly summarize a patient. And so Chat EHR as a tool is something that I use every day. physicians at Stanford are starting to use every day. And it makes our work more efficient because instead of having to peruse the chart and search for answers, the large language model just provides it for you. And the question now, which we can talk about later, is how effective are these tools? Are they actually saving time, saving money, improving patient care? That remains to be seen. But at least with the actual feeling of the work you're doing, it does feel that AI is making the work that we do feel a little bit more streamlined.
Awesome. So maybe you can touch on areas where you think they are still quite aspirational, where this technology is quite aspirational rather than adding real value.
Yes, I think so. AI agents is something that has become very popular in the past couple weeks to months, which is basically building AI tools that can actually do things in the real world. And so not in medicine, but in tech and in other industries, they're building AI agents to actually do coding, using AI agents to actually help people book flights or to do the actual work that folks need to do. If you were to translate what that would mean in medicine, that would be having an AI agent doctor put in orders or to order a scan or to actually administer the care to patients. And as you can imagine, we're nowhere near that. I know there are startups and folks thinking about how we can actually have an AI doctor, put in orders or listen to a patient's chart, et cetera. But I think right now it's very aspirational because we still need physicians, real people, to put in the actual orders in medicine that affect people. And so, and this is a safety thing. And so I think that is definitely aspirational and people want us to get there, but I don't think we'll be at a place where folks are going to a doctor's office and all you see is a machine and and there's no one around to actually say you have this disease and here's your medication. I think we're a long way from removing humans from that interaction, the doctor-patient interaction.
Okay, so if I hear you correctly, it's basically that AI is able to make things more efficient by performing certain tasks within the task bundle. That basically this is a task bundle of what a doctor or health practitioner is supposed to perform. Now, AI has become very good in performing some of those tasks, but the doctor or the health practitioner is still needed because there are areas where AI is not yet good at, right? Yeah.
Correct.
I saw news about China building a completely AI hospital. Of course, we can't be sure of some of those things. Like it's completely AI. Do you think that is real or just propaganda?
I think I can't speak to whether or not it's real. I wouldn't be surprised if it is real because China definitely is competing with America in the AI race and have more, I would say, courage to push through some of those regulatory humps that in America people would balk at. And so if it's real, I would say I would believe it. I just don't know. I do think that we probably are at the place where something like this can be tried and experimented. We have the technology. It's just about putting all the different parts into one place, like a fully functioning AI hospital. I am not yet sure if human beings or populations are ready for that. And so it's maybe a situation where the technology is outstripping what people's comfort level is. I think when it comes to medicine, there's still a sense that you want a doctor, and maybe I'm biased because this is my profession. And so I don't want to see, at least quite soon, a fully autonomous hospital where no human.
Don't want AI to take your job. Just say it.
Exactly. Exactly. So I acknowledge that bias. But the real question at heart is, if AI can do all the parts, all the tasks of being a physician, then what is the role of a physician in the future? What do we actually provide? If it's not to order, if it's not to analyze a result, if it's not to collect information about a patient's case, if AI can do all of that, then does the role of a doctor become someone who sympathizes with you, who can hold your hand and say, this is the diagnosis that you have? Yeah. Or is the doctor someone that's sort of your cheerleader and says, this is everything that the AI has done, but I'm here for you. Keep going. I know in my practice, you can give people the information, but how you give it is just as important as the information itself. And also doctors, because of the relationships they have with their patients, can be the folks who like instill that hope that gets you to do that next chemotherapy appointment because the doctor believes in you as much as they believe in the medicines as well. And I don't know if AI, at least at this moment, can simulate those human to human interactions that are important in medicine.
Awesome. Thank you. Now, let me move to Maureen. Maureen, I'm focusing more on you building the medical devices, right, in Uganda. But of course, you wear so many hats, so you can touch on other things that you're doing. What is the conversation around AI look like from where you are, from where you sit? Are the tools being designed for the context, like yours?
Thank you so much, Dr. Kenyan. Thank you so much, Dr. Chidi. I enjoyed the discussion. And I think I'll just start from what Dr. Chidi was speaking about. First and foremost, I think where the world is seemingly headed to, knowingly or unknowingly, is making AI a replacement for humans. And I think that's an error. So, for example, we are sitting in a case, currently postdoc at UCT, and we are having students that are no longer doing their research. Students are no longer writing their thesis. Students are no longer, working on their presentations actively. So AI is replacing them. And then I think there was a recent article on Lancet speaking about how most of the papers now are just AI generated, AI references. And I think that's dangerous, especially speaking about the academic field, because the academic field ends up affecting almost every. I mean, clinicians use articles maybe to, in their discussions and the engagements, in the hospitals, engineers do the same. So academia is like the foundation of knowledge. So if this is happening in the academic sense, then I think this needs to be regulated. And I see that now there are lots of discussions. I was just looking through social media, and the Pope was talking about how AI should be regulated. And I agree. AI is a tool. It is not a replacement. And it's just now, I'm just like even thinking, because right now we're sitting in a space whereby we're asking ourselves, okay, so should we develop tools that can check whether the students are actually writing the papers, whether the references are okay? Like, can you imagine? We're starting to think like this. So this is what's happening in, like, in Cape Town. I'm sure in every other country, that's the thing, because we have to work as smart as the students are. But then in terms of AI in healthcare space in Uganda, I do not think it's well adapted. And I think that it's not the problem of now, right? So, for example, I'm engaging with, so we want to have a couple of trainings with clinicians of our device and all that. And some of the things that keep popping up is how there's no longer funding for trainings, right? Because USAID pulled out. So now, who are we to introduce AI when the actual nurses being trained are not being trained? So the gap there is not, potentially maybe AI could come to help to train, the nurses and whatnot. But right now we're just looking at how can we meet that gap that USAID funding left, right? Because it's not just happening in Uganda. I was chatting with someone in Zimbabwe. It's happening in Malawi. It's happening all over Africa, right? So I think the AI discussion, I'm not sure whether it's ripe for sub-Saharan Africa. But again, I know that there are lots of innovations coming up. And now when we speak about innovation, sometimes we get people that innovate without understanding the problems. And then when they want to take their innovation on ground, what happens is they are resisted because they're not solving an actual problem. It's their illusion. And I think being an engineer, I kind of I helped myself against that, because we have a tendency of, oh, I think this is a nice and fancy innovation. Let me do something about it, and then we take it to the people and they're like, what is this thing? I don't understand what you brought to me, you know. So that's where I would answer your question. Over to you, Dr. Kene.
Thank you, thank you. That's very insightful. And with regards to the USAID thing, I think it's something for us to really look into, because, of course, one thing that it has surfaced is the idea of the negative impact of depending on another country, right? Because basically you are depending your whole existence on whoever they vote into power, as we've seen over the past few years. Now, you do mention that AI could actually play a role in educating some of those nurses, and I agree with you strongly, because I think one of the areas that I think the AI could become very, very effective is this in education. We've seen it work. But that is, maybe we'll come back to that in terms of how we can actually leverage these tools for upskilling African practitioners, especially in rural parts. There are places, for example, in Nigeria, rural parts of Nigeria, where you travel several kilometers before you can even see a small clinic, and there is no nurse, there is no doctor. Like, so there's a lot of work to be done. Now let's move to Maureen. Maureen, maybe I said let's move to Faith. Faith, just from you are basically, I think you are engaged more with the physical AI, but just tell us a bit about what is happening, how you guys are embracing these tools, and any other insight you have for us.
Okay, thank you very much. So when it comes to the use of AI, I would say mostly in the word setting, is not really as efficient as people say it is, because most of the parameters that are placed in the AI, for example, the blood pressure, does not really reflect in the African setting. So you are seeing that is saying a blood pressure of maybe 140, 90 something, 140, 90. We say that anything from there above is considered hypertension, a high blood pressure. But for most African people, and especially here in Nigeria, quite a number of people have BP way above that. So it throws a lot of errors, like you have like this red error message saying that this is wrong, this is not what is meant to be, but it's not taking into account that the people of Nigeria and of Africa, this is a normal parameter for them. So
Can
is
I push back on that, if you don't mind?
yeah,
Before you
sure.
please, Muriel and Chidi, you can come in here. I want to know, is it that we have normalized pathology? Because, for example, literally every Nigerian behaves correct mentally, but if you actually run a diagnosis, like probably 90% of us are sick. Is it that should we accept that we've normalized pathology, or we should accept the fact that human nature has a way of adapting to pathology, that it's able to survive in spite of it? So when you are able to survive in spite of certain conditions, is it now okay? Is it the optimal state? I want their input. Sorry, before you continue, because that point is.
I think Dr. Chidi, you can go for it.
Okay.
Yeah, that's a funny question. I think so listen, I don't practice in Nigeria. I don't know what the average blood pressure is in Nigeria. I will say that as a physician, if I see someone with a blood pressure of 140/90, no matter where they're from, I would say that we should work on getting it lower, because that technically is hypertension. Now, your point, Faith, though, is right in that if so many people have that blood pressure, then the question becomes, what is happening on a societal level or on a big picture level that we can do to bring that down? Because for me, that indicates that there's something widespread or that's like causing people's blood pressures to be 140/90. So instead of like saying you, sir, are doing something incorrect, the intervention should be, what can we do collectively to bring this average blood pressure down? I will say though, so that's for blood pressure, but white blood cell count is something that has a very standard range, like 5 to 11, that is normal. But if you take my white blood cell count, my sisters, we're Nigerian, ours runs around 3. And that actually is normal for folks in West Africa. It's really well documented that people from West Africa just tend to have lower white blood cell counts. And so in Western charts, it'll be red, like you're saying, Faith, that number will be red. and it will say that, oh, you have a low white blood cell count. But actually, for the average population of Nigerians, when you do these studies and people have done, it actually is normal. And so I will definitely stand by the point that you're making, Faith, which is that westernized ranges and ideals in medicine are trained on like white men from the Midwest, and then they export that to the rest of the world. And so certain numbers look wrong or off when in fact they just hasn't been studied for what's normal in that population. I think blood pressure is different because that's been studied across in many places, but yeah, it's a nuanced point.
Okay, let me hand over to Faith. I think the reason why I pointed that out, because one thing I've observed for us Nigerians, especially in that country, is that everything stresses you. So in order to cope, we develop coping mechanism. You have to come to a point where you just normalize things, right? So that's why, but like you said, Chid, I understand it's very nuanced. So there are situations where there are biological factors, maybe that actually makes it make the criteria for judging something different from one another. And that also begs the question of, if we are using models that are trained on the Western data, because currently only about 2% of the data within this model are from Africa. If you are using them, how effective they are for us, considering all the complexities. But anyway, continue, Faith. I think you are making a very important point there.
Okay, so it's also you were mentioning, you also talked about white blood cell. I want to say that before I started working as a peri-op nurse, so we had this EMR that we were using, and the issue with is a dialysis center. So the issue with that is that because they have kidney failure and other pathologies that comes about from the kidney failure, their red blood cell count was always low. So we work within the range of, if the patient has 20%, then we can go ahead with that. But this reason, because 20% is not normal, it's not the normal range that they should have. So this AMR that we're using, because of that, you won't be able to do anything on the patient. You won't be able to proceed screen. They will just be like this big red warning sign that this patient's PCV is 20%, and we cannot proceed from that. So because it was not tailored in a way that shows that, oh, we can actually proceed, because this is a standard that is allowed in Nigerian Dialysis Center, we had to change from that and then use a more like a localized EMR, one that was done by a Nigerian company, rather than using the one from outside. So apart from just in the world, when we talk about the operating room and robotic surgeries, we have various misconceptions, especially for the layman. The layman believes that the robot is the one doing the surgery. The robotic system we have here is not autonomous. It can't do anything for itself. If you tell it to move, it will move. If you don't tell it to move, it will not move. Right now, you're just staying in the theater doing nothing, because there's nothing it can do. However, the benefits that we hear, which is precision, 3D visualization, reduced hospital stay, minimal scarring, those are true. Every benefit you hear, it is true. But the aspect whereby is the one that is doing the work is not, because the outcome of the robotic surgery depends on the expertise of the surgeon that is doing it and the clinicians that are in the room to be able to take charge, because the surgeon can't see. Why the robotic system has 3 components, which is the console that the surgeon sits on. When he sits on it, he's just looking straight into the lenses. He can't see the patient on the operating bed. Then the robotic system is the second component, and the patient cart. So connected to this patient cart, we have like screens that allows us to see what the surgeon is seeing. But the people who are beside the patient are the perioperative nurse and the surgical first assistants. So that's why communication is usually very important when we're having a surgery. If we cannot hear the surgeon, the procedure will not go on. And if the surgeon cannot hear us, the procedure will not go on. So it's not why AI and the technologies we have, they are not as advanced as we think they are. They actually are doing a lot of work. We also have the coming up of telesurgeries. So we have had 2 cases in Africa here. We have a situation whereby the surgeon was in Florida and the patient was in Angola. We also have the case whereby the patient was in Morocco and the surgeon was in China. So this usually, there's like a lot of connections with the fiber optic cables and 5G network. These two instances of telesurgery, they were done under an FDA-approved clinical trial. But the possibility of that happening continuously is very minimal, because apart from the connection of the fiber optic cable, we're also looking at 5G network. And even with Starlink and everything, you still have network connections. You don't want a situation whereby something's wrong with the network. We now have to start undocking and doing traditional surgery, like, is really a lot. So apart from having a specialized person in another country doing it, the local surgical team on ground should also have expertise on how it occurs, because if the local surgical team doesn't know how to dock and undock the robots, there's like a lot of issues on ground. But apart from just the benefits to the patient, there's also benefit to the surgeon, because there's less fatigue on the surgeon. Most of the surgeon does not come in until docking is done. So after the docking, procedure takes like about 1 or 2 hours. But every other thing before the surgery itself is what elongates it. So you have a surgery of 5 hours. The whole surgery is taking 5 hours. So that whole aspect of, if you do robotic assisted surgery, is very fast. Before you know it, you're out. It's not fast, because there's a lot of time that goes into position. In fact, you can even spend 3 hours positioning the patient if you are not careful, than even doing the procedure itself. Then when we talk about, there are a lot of robotic systems in place. We have the Vesios, we have the Tumai, we have the Da Vinci robotic system. In Nigeria, we have it's mostly the Tumai that is in place, that is in use. Then we have just one center, which is where I work, that uses the Da Vinci robotic system.
In the whole country?
Yes, in the whole country. So in total, in the whole country, we have just 5 robotic centers, just 5. But it's 3 that are very like in use. But we have 5 in general. The 5th one is still upcoming. They have not started receiving patients yet, but we like to count them.
Thank you. That's very, very insightful, Faith. You pointed out a few things that I want to kind of dig a bit further. Basically, you are saying that no matter how powerful these tools are, it's still the effectiveness of the process is still contingent on the person who operates them, the human layer,
yes.
Right?
Yes.
And that, as we were talking, I just talked about the fact that, for example, in 1970, the type of computers that people were using then, if you compare it to what all of us have in our pockets, the transistors. So, for example, now what we have now has at least 100 million times transistors than what used to operate in the 1970s. Now, if you just judge based on phone alone, phone capability compared to computers in the 1970s, we should be 100 million times more effective in what we are doing. But are we really 100 million times more effective? We have way more powerful phones, but we are not as effective. Maybe we are 2 or 3 times. So the translation of the complexity and the power of a machine to actual outcome is now contingent on some of those weak points. And usually they are with the human layer. Are we trained enough? And also we have the issue of we only have certain hours of the day to work with. So I think that's one area of hope for people that are scared that AI is going to take over all jobs. No matter how powerful these tools are, there will still be fulcrum areas where humans have to play. And because humans are not moving in the speed of light, with the speed of light, I think it's going to hold things a bit. Then you did mention something about that I want to do parallel, something that even if you are doing all this telemedicine, you still need to make sure the people on ground are well equipped. It reminds me of a situation where we faced, because we built software where you have all these groups, everybody's now building software because they can vibe code. They've vibe coded, they launched the thing, but somehow there is a bug, the thing is not working. They are helpless. So when you don't have people that actually know how to do this stuff, you are now stuck. A client recently reached out to us. We now have to start from start again. After she has spent a lot of money on bank credit, we have to start from beginning. So I think that's a very important. Maureen, you have something to say?
Yeah, thank you. Wow. Thank you so much, Faith. I'm so amazed. Wow, it's amazing. I think as you're speaking, I just thought about something in terms of regulations, right? Just 4 questions. What can AI do? What do we envision AI doing? And then in terms of regulations, what should AI be doing? And what should AI not be doing? And I think when we're talking about, I think it's something it's a discussion that's upcoming in terms of AI regulations, especially in the healthcare space. And I think these are some of the discussions that we need to really incorporate, as innovators, because we are the ones that set the tone of AI, right? I liked what you said, Dr. Kene. It all comes back to us, right? And I think on maybe also just mentioning something to do with what Faith said in terms of feeding the AI models. I recently just was attending a conference in Nigeria, Lagos, and one of the speakers spoke about how all this technology aspect, it's based on information that's given to it. And many times Africans do not want to give information as opposed to just utilizing information. So I think it's also upon us to begin to create AI models and feed these AI models with Africa-centered information, because I can imagine getting an AI system that thinks this is the US that has like all these, everything is advanced, and then it starts operating advanced, and at the end of the day, it's frustrating a system, So I think maybe that's an aspect to do with adoption, and maybe why some AI innovations have actually not been adapted in our setting. Thank you. Over to you, sir.
Wow, that's very, very, very important. Thank you so much for mentioning that. I like the way you categorize some of the critical questions. What is AI currently doing? What can AI do in the future? And what AI should? Now, that should is the most controversial, because some people that are just really care about efficiency, as long as we can get this model to do it, it should do it. But you are coming from an ethical point of view. Even when we can, there are things we shouldn't do just because we can. Can you throw more light on that? What should be the guardrail? How do we decide what we should do and what we shouldn't?
Well, I think, thank you so much, Dr. Kene. I think I would like Dr. Chidi to respond to that based on his whole understanding of the ethics and,
Yes.
because
Okay.
it just back to the ethics code that doctors operate with. So if we are to say that AI in courts is replacing doctors, which will never happen, because we appreciate that doctors' interaction. I know that some patients just get healed by talking to a doctor, not talking to an AI robot, I think, and also just maybe just before Dr. Chidi comes in, maybe just looking at even the aspect on, I know there is confidentiality. Are we sure that AI keeps information, confidential? I don't think so. I mean, when I put information on ChatGPT, I can find it somewhere else, So, like, over to you, Dr. Chidi. Thank you.
Yeah,
Chidi,
no,
over to you.
yeah, these are great questions. I think about this all the time, specifically the medical context in 2 ways. One, medical education. And so when I went through medical school 2014 onwards, there was a sense that you were going to school and you were reading and learning about the fundamentals of medicine because you had to just have it in your head before practicing. Like you needed to be able to retrieve that information, the basics. Times have changed now that AI is here, so that people in medical students can ask a question to a large language model, any specific question, and get an answer like that's complex and beautiful and like more thought out than they would have otherwise generated had they looked it up itself. And so the question in medical education, and I'm going to a medical education and AI conference in a week or so I'll have more insight. But now that AI has entered medicine, what is it that medical students should learn in order to be good doctors in the AI world, because now we have systems that can just retrieve knowledge and synthesize knowledge just as good, if not better, than the average first-year medical student. And so we have to be really asking ourselves, like, what is it that we want doctors to do, and what is it that we want AI to do? And then we have to make sure that we're educating and training physicians to do what it is that we want a physician who is a human to uniquely do that AI can't. And so I think people are thinking a lot about that. And it's, change is the fundamental constant in life. The way people were learning medicine in the 1800s is different than they were learning in the age of the internet. And it will be different in the way that they learn now that AI is there. And so those guardrails, what do we want to safeguard for medical education and for doctors, is like an important thing in this age. Then to your point, Maureen, I think it's a good one. Like, where is this knowledge going? I take it a bit further and say, these are capitalist institutions that are making these systems. And so we talk about AI as like a tool, and Dr. Marine, you're right. Like, you put in knowledge and it goes into the ether. And I know that this knowledge is eventually going to be used to be monetized, because the systems that are building these tools, they're not agnostic to capitalist forces. And so we have to be really careful about, and to always have that in the back of our mind, that they're not being generated in a vacuum. Like, ultimately, these companies want to make money on our data, because data is like the new oil of the 21st century. And when it comes to health, you have to know that at some point, somewhere, there's money to be made on the information that is being generated. And so I know it's a scary point to make, but it's a good point, which is that, people are trying to make money off these things, off these tools. And so your data is going to be monetized.
Yeah. Okay. Awesome. Thank you so much, Chidi. Faith.
Okay. So when it comes to the aspect of education, I do believe that AI should be used for education, because it makes things way easier. I don't want to have to, I'm saying that someone who is also schooling, I don't want to have to go through 50 publications just because I'm trying to find one thing. It's saving time. I'm not about to spend 50 years doing one project when it is possible to do the project quickly. But when we consider the fact that, but in practical use, I also don't want to impute my patient's details into a model that is going to carry those details to God knows where. Because what's the use of spending so much time learning about confidentiality and how you should not breach confidentiality if the advancements in technology would cause my patient details to be exposed? Everybody has a right to privacy. And what AI should not do, and I do not believe that even in 50 years it will do, is replace the work that human beings are already doing. When a patient comes to the theater and you want to start the procedure, the patient does not want to see a mechanical robot at the door welcoming them in. That's not going to work, because the way you welcome the patient into the theater will affect the patient's emotional stability. And the things about human being is that when somebody is anxious, it will show physiologically. You will see an elevated pulse, you will see an elevated BP, and the patient will not want to interact, like will not want to agree with whatever is going on. Like when we receive a patient, so the way we do it is that we do spinal anesthesia, whereby the patient has to lean forward like this, and then we give the anesthesia spinal before giving the general anesthesia. A patient who was not welcomed properly and made to feel comfortable will not agree for us to insert a very long needle into their back, simply because we want to make them fall asleep. I've had a lot of patients that have said, even with the whole explanation and everything, I've had a lot of patients that will say, no, I don't want spinal. Or I've heard that if you do the spinal wrongly, I'll become crippled. Allow for a robot to not be the one to do that. Me personally, I would not allow that. So that's something that is actually very, very important. So when it comes to the educational points and the educational, I feel like there's still a lot of work that can be done, especially in the education of we that we are here, whereby we don't have access to a lot of surgeons who are use this advanced interventions. Like Dr. Chidi mentioned, chat HER. I'm not sure if I'm saying it well. HER. Never heard of that before. Never heard of that before now. We also have this thing that we had a magazine that they brought, Sasha OR, who is like a robotic perioperative nurse that they are starting to introduce into some countries. So what she can do, or what the robot can do, is to pass instrument autonomously. Nobody's telling her to pass it. She just knows that it's time to pass it, and she passed this. And they're using it in some countries. Never heard of it too before we saw the magazine. So when it comes to the use of AI in educational system, it can help us to bridge the gap whereby we don't have the human workforce to do it. But when it comes into practical use, there are a lot of ethical dilemmas that we need to look at, rather than just looking at the benefit to us as clinicians and not just to the patient. Thank you.
Awesome. Chidi, there is a lot of work for you and for everyone, but I like that she was pointing. Okay, Chidi, you can just come in.
Yeah, I'll come in and say, Faith, I love your point about the educational aspect, and I use it all the time for educational research purposes. And I know it sounds like we've been on a slightly negative side of AI, but I will say something very positive about it, which gets to your point, Faith, which is that it really democratizes information in a way that we haven't seen before, with tools like open evidence, but also just cloud and ChatGPT. Physicians, healthcare providers from around the world, no matter their level of training, can ask a question and they have the world's knowledge at their fingertip to answer. And that, I just think, is a net benefit. The same with patients. Patients are now more empowered to be able to understand their healthcare data and to be able to generate good questions to come to doctors' offices with, or to better understand their symptoms, because these tools, beforehand, medical knowledge was in journals and was behind paywalls on online subscriptions. But now, if you have access to these tools, that information is available to you and to physicians around the world. So you kind of can have specialty knowledge, even if you are from a low resource setting, as long as you have access to these tools. And I think that overall it's a net benefit.
Wow. So, but I still consider it as a potential, because we need to actually help our learners, the students, to actually know how to learn with these tools. Because like Maureen pointed out, the problem, and I'm seeing it even with our own training program, is that the human tendency to take the path of least resistance is to outsource our work to these tools. Do this thing for me. Now, you see a situation, for example, in academia where students are using AI to generate all their assignments. Lecturers are using AI to grade their assignments. So it's AI judging AI, and that is the situation we are having in the world today. And it's really important that we think through, how are we going to, what scenarios do we need to create to actually make us so that we are able to raise healthcare workers, train them in a way that they adapt. Because it's one thing for a school to say, no use of AI here, don't ever use of AI. If we do that, we're actually robbing the students of the opportunity, the power, like we mentioned, these tools have. It's another thing, that's one extreme. Another extreme is to say, everybody just use AI to do whatever you want. And so it becomes a problem. So I think it's, how do we create a structured work? Because the potential is really massive. I like what Faith pointed out in terms of some of the things Dr. Chidi was saying that she has never heard of. Of course, Dr. Chidi was trained in two of the best universities in the world as far as health is concerned, right? Now, imagine if we can have a model that is specifically, let's say, for example, it is a unique model that has all those knowledge inside, but customized to train African workers, because it understands African demographics, it understands the data, it understands the African personality, and it begins to coach these students to be locally relevant, but global information. And that is how we begin to adapt some of those innovative stuff so that we implement it. But it's not going to just come because there's potential. We need to find a way to translate potential into reality. And the sad thing is that the rate of technological space far outpaces, whether it's policy, whether it's implementation, whether it's education, they are moving at the speed of light. We are still walking, right? I think that's where there is a serious gap. So that's one thing that I want us to really focus on, and I really want you to come in strong here in terms of how we would what we need to do as far as education is concerned. Every year, Africa releases into the labor market 325,000 health practitioners every year. Now, a lot of the schools, a lot of the universities are still using the old curriculum, meaning you train somebody to come into the office mostly you train them to remember the information so that when they come to the world of work, they start actually, they practice and they learn and they grow. Now, the world is changed where the calling information is no longer needed because there's computer there for you. So as we are having this conversation, for example, I asked my AI, how many healthcare practitioners is produced in Africa every year? It gave me the answer. I didn't have to memorize that, right? I didn't have to. So recalling information is the easiest thing now, but we are still training for that. We need to now find out what are those things that humans still need to be doing, and that is why this conversation is important. What are those things that humans still need to be doing in this era so that the educational institution will focus on helping to nurture those skills so that we are training these talents to operate in the AI era. Now, thirdly, Faith did mention something about managing a particular patient situation is beyond just giving medicine or prescribing. A human will weigh in on the complexity and know how to relay the information. It reminded me of an article I wrote recently about the doorman. So there was a story that in a London hotel, because they have this automatic door, they decided to sack the doorman, the man that used to work in front, that used to open the door for people. Now, months later, they realized negative things begin to happen. A reduction in number of people that were booking into their hotel. When they started studying, what they realized is that doorman was not just, even though the description on his contract was open door, he was doing more than that. He was the face that was smiling when guests are entering. He was the face, for example, when, for example, it's raining and the guest is coming out of the taxi, he rushes with the umbrella to go and shield. He was, so we judge human workers mostly by output, the economic output of work. You have to do these tasks. But we are an embodied being relating with one another. There is more to us than the output of our work. And we need to factor that in terms of how do we nurture those things that actually make us human, right? So that we begin to use these tools to elevate whatever we are able to do. I remember one of my mentors said something. He said that maybe with AI, we'll start being human beings instead of human doings. Because right now, the focus has been what we can do as humans and so on and so forth. But let's drill down on the education aspect, right? Like we really need to think about what kind of structure, Chidi, from your vantage point, let's start with the US where you are very conversant with. What kind of education do you think will help? You know what you went through, have to memorize a lot of medical stuff. Sorry, it's one course that I tried, but it's one course you guys work really hard. People in the medical area, no. Like if you are to consider what you know now in terms of how AI is changing learning, what are the areas that you need to focus as far as the educational institutions need to focus on to produce the medical practitioners that are prepared for the AI world?
Yeah, fantastic question. I'm excited about this question for a couple of reasons. The first, I think the answer that I will give you right off the bat is you're right. Recall is something that you can just do away with. There's just no need to train students to recall information. It's a literal waste of time. We already have Google, which people were doing, but now with AI, you can recall things that are even much more specific and complex, and you don't need to do research for it. And so I think that skill set needs to go. I do think in medicine, there are certain baseline facts and certain diseases and disease states that you just need to know in your being because they're very common. So I do think that's important, but that's more at the level of diseases and how people present. But basic physiology, basic science, all of that you can do away with. I think what we need to train students to do, number 1, 2, and 3, is critical thinking. People are still trying to outsource critical thinking to AI, but I think that is a mistake. I think to what we are very good at and should be able to do, especially as physicians, is to be presented information. So here's the recall, here are the facts. How do you actually think through this problem? And that is something that I worry about with students going through college right now, and definitely people in professional programs. That aspect of critical thinking is also being outsourced to AI, but you have to be able to develop your brain by solving problems and thinking through problems, because that is actually the work that is you're going to be doing in the future, even with AI. Like, no one is going to say, oh, doctor, you copy and pasted what AI decided this case was, and even though it was wrong, I'm not going to sue you because AI did the thinking and not you. Like that's never going to fly. At the end of the day, you as a human being need to be able to actually do the critical thinking, because these tools are not infallible. Humans are also not infallible, but you need to be able to see something that an AI tool generates and be able to say, this feels right, this feels wrong, or there's elements of this that are right, but there are parts of it that are wrong. So I think we need to be training physicians to do that critical analysis, critical thinking, thinking through a case, and coming up with differentials and plans that make sense for a patient. So that's number one. I don't think that should ever be outsourced. The other thing that shouldn't be outsourced is that, and I don't know how to describe it, but it's this ability to practice empathy and to be in community and in a space with the patient. That is also something that you learn through medical school, and we should never also have that outsourced, because what do people want, as Faith says, when they enter an operating theater? They want to know that there's a human being who cares about their success in this case. And believe it or not, that is something that you learn in medical school, because you have to be comfortable in that space. You have to know what the risks of a procedure are, and you need to, through time, practice the right words that for most people will make them feel okay. And that takes skill. You go through residency in 3 years. I saw patients pass away. The first time I had to talk to a family member that their loved one passed was not as good as like the 50th time that I did it. And it's kind of callous to say, but that is a skill. You have to learn how to be comfortable in death and be comfortable explaining to someone that their loved one has died for these reasons, and to be able to sit with that sadness. We shouldn't export that, because I think, at least right now, people want information like that and that emotional headspace to be with a fellow human being. I think Dr. Maureen brought up the Pope's recent like Magnificus Humanicus, or that 43,000 word document he wrote about AI. And one of the points that I haven't read it, but I've read summaries. And one of the summaries that I really like that he talks about is the fact that at the end of the day, we are driven by relationships, the ups and downs of that. And we shouldn't let AI confound or interrupt the relationships that we have with each other. So when it comes to medical education, I think that is something that we shouldn't outsource, the relationship between the doctor and the patient. Yeah.
Well, awesome. So critical thinking, empathy, and relationship. And actually, those are actually some of the things that actually make us human, right? Because usually, for example, there is things like, for example, sports. I could play, for example, a sport with an AI tool. Let's say chess. I could play chess with an AI tool. But it's different from when I'm playing with somebody, like a human. Like, we want to come. There's something about the chemistry, the interaction. We want to become better, right? Yeah. So I think it's really important. We humans, yes, these things could be very efficient. They can do amazing. But we need to actually make sure we are, at the end of the day, the aim should be that it should foster human development. And human development, it's, of course, we need to look at how we relate with each other, how we grow with each other. It's not just about growing the GDP of just producing for the sake of producing. As somebody put it rightly, he said that, for example, imagine, for example, if you are giving billions of dollars, but you live in an island where it's only you, there is nothing, it's just you, just eat food. Would that be life? So, and that brings us back to what Maureen said earlier on, that we are optimizing for the wrong things, right? Everything is really, we need to think about what should we be doing with these tools, not just what can these tools do. Now, let me move a bit towards Maureen, right? Maureen, I want you to just tell us, like, for example, still in talking about education, what would an AI fluent African health worker look like? Like, what are the skills? Because, for example, the skills they may need in the US may not necessarily be the skills they need in Africa. So, for example, Faith might be doing an operation and realize, for example, that she needs to switch on the generator because NEPA has taken light. that is not relevant when you're operating in the US. So what are the skills? What are the authority? What are the training? What are the things, if we want to structure a training program for healthcare for Africa in this era, in the era of AI, what are the things we need to actually make sure that we take care of?
Thank you. I think I'll just start by just adding another point to what Dr. Chidi just mentioned. And I would say training, and thank you for mentioning that skills training, right? So, for example, if we are to give students, let's say, write an essay, at this point in time, our students will most likely send us AI generated essays, right? If we had to tell them write a thesis, it will be an AI generated thesis. But where we catch students is when we give them a practical examination. There you cannot, where is the AI? Where is the AI there? We have you where we want you, right? So I think it's something that I was just having a chat with my supervisor, and I was telling him that previously there's a department that we're in, and that I was in, and the students, they were not defending their thesis, right? So it was just basically write your thesis, submit, get your A's and whatnot, But now they have actually introduced the defense of the thesis. Of course, some students are able to memorize, but once they ask you some questions, you'll have to prove that you did the work. So I just think it's also becoming as smart as the students are, smart as we can't do away with AI. We can't at this point in time. For example, we can't do away with telephones,
Yeah.
But then how can we also train people, like, for example, children? I have a cousin. How old is he? He's 5 years with a telephone. I'm like, bro, what are you using a phone for at your age? I got a phone when I was like 15, right? But then I'm like, okay, this is where now we have to work with the current system. It's not 1900 anymore. It's 2026. So how can we, it's more like, and I think it comes back to the question you asked me, Dr. Kelly. To me, it's more about understanding the terrain we are working with, especially in Africa. Especially like now, I'm just juggling with education, and then also the medical space, right? Understanding the terrain we're dealing with, right? So, for example, I at this point in time, I see AI coming into train. That is it. I do not see AI coming into the theaters or to, to replace a doctor and a nurse somewhere. I don't see that, because I was chatting with a managing director of one of the hospitals, and he told me that, Maureen, before I came into this hospital, there were so many deaths that were happening, right? There were so many women that were dying because of postpartum hemorrhage. And then he said, when I came in, what I simply changed was I simply just added more trainings. And with more trainings, with encouraging diligence in their work, the nurses are happy and mothers are not dying. I'm like, okay, so that's the secret. It's just the training. Put aside us introducing all this fancy equipment, all the software, all this and this. It's just the training. When you train people the right way, they'll be able to solve the right problems the right way, right? So now how AI can come into this space is just in terms of the training. Can we train the people to do what they should do appropriately? And then we can start talking about, oh, let's introduce this and that, the fancy, the this, but let's sort the first things first. Let's deal with the training. So those are just my thoughts from a medical engineering perspective, not as a doctor in the clinic.
Yeah, absolutely. No, thank you so much. That's very, very insightful. And guys, please, if you have questions, maybe you can write it down in the chat room, or you raise your hands, so that, because we have just about 15 minutes. So if you have a question from the audience, just raise your hands, or you can ask it in the chat room. Still talking about education. Now, the challenge is that prior to now, it is in the process of actually doing those hard work that we learn. So Maureen talked about essay. You give a student to actually go and do an essay, give a task to do an essay. Let's say he or she checks online on Google, get the material, and begin to mix them together. It is in that process, apart from, for example, being conversant with the terms and everything, because you need to understand things before you can mix them, right? That is the process of the cognitive work that we do, the cognition process that we exercise actually helps us to not just familiarize ourselves with these things, it also now helps us to be able to do them. Now that AI can just actually cook the food for me, somebody compared it, say, but with AI, Google search will give you the ingredients. You still have to mix them and cook. But ChatGPT will just make the food. Now they even format it for you. I give you PDF. They say you should submit, right? So that means that those useful cognition that we used to exercise, we are robbed of the opportunity to exercise them. But that doesn't mean we should throw away the use of AI. We need to think, what other methods should we use to ensure that we're exercising those? Because how would you judge the output of an AI if you actually don't even know it? Now, all of us here, for most of us, Dr. Chidi, for example, was trained in the normal medicine. So when he sees AI being wrong, he can identify it. What about a student today that is just being trained and is using AI to do everything? He doesn't have the experience to actually exercise the judgment. So using AI for the sake of AI is not healthy. So we need to think through. And the worst part is that universities have not even yet adapted, right? So they are still using the old method, go and do the assignment. And these students, as smart as they are basically using AI to do it. So they are being robbed of the useful cognition that used to exist in the old era. So I think it's something that we need to think of. How we are dealing with it at Mozisha, not in the health, but in the tech space, is this. Practice-based, and Maury mentioned this. Everything really has to be about practice. In the old era, it's really about how you're able to fetch the information and how we're able to mix it. Now, in fact, our philosophy is this. In the new era, work is training and training is work. What do I mean by that? When you come to, let's say, a sandbox that we built, a simulated sandbox using real workflow, let's say medical workflow and real data, and you are supposed to actually assess a certain situation and let's say give diagnosis and everything, AI provides you with all the information. But you make the decision and you see the outcome, then you reason the outcome. Now, when the outcome is benchmarked against what is supposed to be, if you give it pass and AI say it's wrong, it gives you information you need to read to improve your understanding of that terrain. You go back and exercise it. Now, so you learn by doing, and then you build that judgment by cycles of decision making, doing, because we simulate this real workflow, and it's very easy to do that. So as you begin to make decisions, so like the education of this era should more focus on doing, practice. Because the access to information is now very easy. AI now provides you with that information with which you make decisions within the practice domain, and then you keep refining and refining. So I think, yes, we need to actually upgrade our system of training. The old era cannot work, and we hope that universities and other education institutions are able to catch up. Somebody has a question. Oh, Divine, is it a comment or a question? Okay, it's a comment. Okay, I thought it's a question. Anyone? Faith? Yes, Faith, you are going to talk, but I also have a question for you, so you can answer it as you are talking. Now, in many ways, what do you wish you had been trained for that you were not? Like, considering what you are doing now, and you are learning, and you are working as a nurse, what do you think it would have been better for you, would have performed better if you were trained for this? Then you can, of course, make the point you wanted to make.
Okay, so I don't really think there's much that could have been done differently than what was done while I was in school, because my school, which is the school I trained in, which is Lagos University Teaching Hospital, we focus more on practical than even the theory itself. So before, while I was still doing my general nursing, before I did the therapeutic nursing, while I was still doing my general nursing, there was a change in curriculum whereby the amount of hours that we spent in class was reduced, and we spent more time going to the wards. And apart from, after going to the wards that were in Lut, they took us to other institutions. So we went to Lasut, which was a state. We went to other federal institutions in another state. Then we also went to private hospitals. So we had a rotation in Evercare. So the thing about federal universities and their hospitals is that they are not equipped with the best state-of-the-art interventions and technologies. But when we have private hospitals like Evercare, Duchess, and Lagoons, those ones, they have those equipment in which we are looking for. And then the Education Board of LUT realized that they did not have this equipment. There was nothing they could do about it while still waiting for funding. So the best thing they could do was to partnership with Evercare Hospital for us to go and see what the work looks like over there. So when it comes to my work specifically, we were not able to, just a one-time visit to where I'm currently working. But like I said before, we have just 5 centers with 3 that are functioning better than the other 2. So not a lot of people could go, and the set after me, they could not go because they had closed their doors to other people by then. So what can be done right now is, first of all, we need an infrastructure that can actually hold these technologies. Number one, we need people that are already learned in dealing with this infrastructure to come and teach the people that have not yet had an opportunity to use these technologies. Because now that we have this infrastructure, we need the technologies in those infrastructure. We need people to teach us how to use those technologies. I will give an example where I'm working now. So when the training occurred, the training was more on what we are meant to do currently, like in our own job specification. When it comes to troubleshooting and fault management, we are just told, oh, you can recover faults. So what happens is that Mr. A now, so we have Mr. A, who was like a 65-year-old man that had come for a radical prostatectomy. We have positioned him, we have docked the robot, which is basically just inserting the robotic arms into the incisions we have already made. So we have docked the robots, and then we received an error message. And the things about those error messages is that they are not specified. So we don't really know what is wrong. We just have an error message and then a sequence of numbers. So that number is what will tell you that this is the error that the system is picking up. But our training, we never knew what those numbers mean. So we had to take a picture and send it to the technical team to let us know that, oh, so number means that the system was overheating. But before then, because we can't wait, the patient cannot be under anesthesia for too long. That also has its own side effect. So while we were doing that, we have to undock the robot, we have to reposition again while the patient is under anesthesia. So we had to reposition again, we had to undock, redock, check all the ports that is not there was an issue with the port. We have to check that the arms were not clashing, because when the robotic arms are clashing, we usually get a recover fault message. So we had to check all that, redocked again. And why the issue with all this is that there's a possibility that sterility will be compromised. The system cannot tell us when the sterility is compromised or not. It has to be from our own discretion and our own vigilance to make sure that the sterility is not compromised. So we had to do all that. And after doing all this and redocking the patient, the robot back, we got another recover fault message. So there was a lot of confusion, but in this point in time, you can't show the confusion, because the moment you show confusion and you are disoriented, then the patient is at risk. So while we're doing all this and we're trying to push through the surgery, because this surgery is usually very dependent on the robot. If the robot does not work, there's nothing we can do about it. We have to do like a traditional open surgery. While we're doing all that, we got information from the technical people that, oh, it's because it is overheating. We had to increase the AC. So when it comes to training, even on job training, it's a lot of perception that this one does not concern the clinical team. It's the technical team that should know all this. But the technical team is not on ground. The technical team is in US, and we cannot house them with us here. The best thing we can do is that if we have biomedical engineers that actually know how this thing work and are staying here locally, like they are staying here in Nigeria, we can have one in the theater with us each time we are doing the surgery, so that when we see these things, there's somebody we can report to. But while that is still in process, like that, while that is still in work, what we do now is that we ensure that every clinical team members that are going to be in the OR has a booklet that shows the error messages and the code numbers that come across with it, so that next time when we have such a situation, we know what to do. So when it comes to training aspect, there's not a lot of things that we can do in the training aspect in school area, because we don't have these infrastructures that the schools can use. And even on job, like the on-job training, we really need to deal with the perception that some things are for technical team to know, some things are for the clinical team to know. When it comes to patient care, everybody should have knowledge on what they are working with. So, but in general, you're taught, communication, in general, we're taught communication skill, critical thinking skill. You should be able to work in a very high pressure condition, because even a traditional surgery is a high pressure condition. So the basic soft skills that are needed, we already have that in training. The technical skills that we need, we don't have that because we don't have this equipment that we can use for the training. Thank you.
Thank you. Thank you so much. I don't know if Dr. Chidi, you have something to say to that, but a few things that are actually coming to my mind is, I think there's a lot of work to be done. And of course, Dr. Chidi, with the amazing knowledge you're acquiring, I know you are very passionate about Africa, because I've had conversation with you on that. So I'm hoping that with this conversation, you are getting some ideas on where things could be. And I think there is a dire need on the continent. We can't even overstate that, right? There's so much to do, right? There's so much to do. Infrastructure is another thing, because some of those, if we are talking about practical training, you actually need to have those instruments. Faith mentioned it. She mentioned something that in the whole Nigeria, there's only 3 that they have, right? And probably those 3, if I'm not mistaken, would be in Lagos. Faith, what was that you said that there were only 3?
Okay, I said we have 5 in general,
Okay.
but 3 are the ones that are receiving high volume of patients. So
Okay.
we have 2 in Lagos and 1 in Abuja.
Okay, that's just
Those
it.
are the 3 that are really functioning.
And what's that? What's the name again? Sorry.
Name of what?
The machine that you were talking about.
Okay, I said in Nigeria we have the Da Vinci robotic system and the
Okay,
Toumai.
Da
That
Vinci.
is spelled, yes, Toumai.
Okay, so the question is, because infrastructural challenges are very, very costly, right? So you can't really do a training in vacuum. Now, one solution could be, is it possible that we can simulate these things where, so for example, you could actually be practicing how to do a surgery in a simulated environment as if it's real. Now, is that enough to actually prepare you to attempt something in real life? That's one thing. So imagine, for example, you learned how to drive by playing video game. You could do all those things. You could move at the speed of light. Then they give you a car. You realize it's a completely different ball game. So I think there are levels to these challenges. But the question that I really want you to look at, because of our time, Chidi, thinking through what is happening now, what do you think the continent needs to do, both in terms of the government, but also the diaspora community? What should we need to do to really help to prepare the continent to be able to fare well as far as health is concerned in the AI era?
Yeah, I think what Faith said is important, which is number one, having infrastructure. It doesn't make sense to create and then implement all these AI tools into an infrastructure that doesn't exist or isn't robust enough to take on the next step in delivering care. So and that's not to say that AI shouldn't be in healthcare in Africa, because I think it should be, but I think it needs to be done in conjunction with building a robust system that can actually deliver care without the use of these tools. And then once that's being done effectively, then saying, okay, how can we use these tools to do an even better job? But I've been to Nigeria many times, so I don't have experience with the hospitals and the way that care is delivered in Nigeria as Faith does. But what I know from talking to my parents who are nurses here and trained in Nigeria is that there's no national framework for how healthcare should be delivered. It's all based on the specific types of clinics and hospitals that you have in your area. And then they're very expensive for the average person. And so we have a lot of work to do with ensuring that we have a system to deliver healthcare to the average Nigerian. And then from there, saying, okay, now how can we incorporate these tools? So that's from the healthcare delivery space. I do think there's opportunity in the education space. And so I wonder if they're in Nigerian medical schools, how they're thinking about empowering their students to use AI, because we don't want our Nigerian soon-to-be physicians, nurses, et cetera, to be left behind from a global standpoint. And we've talked a lot about this, Ken, about how we feel like Nigeria really, with the rich human resources that we have and the capital we have, can really be a leader in this space. And in sub-Saharan Africa as well, that's where the world's population is growing. And so that's why Mozisha is doing such a good job of positioning sub-Saharan Africa as the next place of innovation and energy and real progress to be made. And so I think the first step is believing that we can even do this in the first place. And this is something we've thought about too. Like, we actually can be at the forefront of these changes, and we can actually modernize and revolutionize the way that we're doing work in sub-Saharan Africa. And there's no reason why we can't be in the rooms, if not leading these rooms too.
Awesome. Thank you. I want to, before I actually round off, there could be other doctors here, but there's one that since Lumbani couldn't join because of the World Health Organization meeting, we have a doctor here from Johannesburg. His name is Ajadi Afolabi. Ajadi, I don't know if you can maybe just make some input from your vantage point. I know you've worked in Nigeria, right? And now working in South Africa. Like, where do you see things in as far as AI in health is concerned? If you have some point that you want to make, please, you can contribute. Hello, Dr. Ajadi. Okay, no, it's fine. Now coming back. Okay, Faith, you have something to say?
Yeah, I just want to say that when it comes to all this, we also have to look at the policies that we have in ground in our various countries in Africa. If these policies support the use of all these technologies, for example, we have a lot of wealthy people, right, in Nigeria. We have quite a number of wealthy people. Now, where are these wealthy people investing their money in? And are the policies for investment in healthcare, is it attractive and favorable to them? Yeah. The government has a lot of role to play in all this, because we need to, federal government have realized that they cannot do it themselves. So that's why they're looking onto private hospitals. But rather, apart from these private hospitals, we have wealthy people that are investing their money in somewhere else. We need to make them realize that the healthcare is also a place that they should invest in rather than going outside. Because if our countries here, if they are well equipped, we can reduce the amount of medical tourism that's currently going on. But when we have the issue of our own president traveling outside the country to go and receive medical care from somewhere else, the other rich people there, they're not going to be looking at the healthcare system of Nigeria and be thinking, wow, this is a good opportunity for me to put my money. So if we can have policies that shows that the healthcare is lucrative, putting your money into the healthcare will not just give you money, but will also help your family members.
Yeah, thank you. Yeah, thank you so much. So ultimately, government needs to incentivize investment in healthcare, right? They say you put your money where your mouth is, right? You can't be going to give British people money every day doing treatment there, and you want your healthcare to be better. It's a sad situation. Now, in conclusion, we all agree that AI could have massive change in the health sector in Africa. But for us to actually actualize that change, we need to ensure that we develop the human layer. I call it the human API that translates AI potential into reality for the continent. Now, we are very lucky as a continent because we are the most youthful on the continent. By 2030, we would have released almost 375 million young people into the labor market. Unfortunately, we are still educating these young people with the old pedagogical approach. We need to actually adapt. So I think a very, very important question. I think from our conversation today, education is something that needs to be doubled down on. How are we preparing these young people so that they are able to operate in the new world? The problem is that if you don't take action to actually change the way you train them, they just use this tool to assess their learning, to actually finish their learning fast, and they become shallow. They're not able to use these tools effectively. They're not able to build the knowledge. Like we said, those useful cognition, those hard labor you engage in is what used to help us build cognition. Now AI does it. So we need to actually rethink how we do education. And there's a lot of opportunity that I think that we have on the continent to actually make that shift. And I think when I look at myself in terms of some of the conversations we are having, I think we are standing on the almost on the base of something that is really, really significant for the continent. Because if we can massively equip these hundreds of millions of young people, who knows? This could be the time that all the leapfrog that we've been talking about for decades will materialize. I really want to appreciate every one of you for making out time for this important conversation. I know there's not enough time to actually really delve into this deeply, but I want to leave you guys. I want you guys to just say, just even if it's just for 5 seconds, just one word in closing to our panel from our panelists. Who wants to start first? I don't want to call anybody now. Who want to go first? Okay, let me. Maureen. Few words in closing. You are mute. Okay, let's go, Faith.
What can I say? Thank you, everyone, for those that were able to join. Thank you, Kenya, for this opportunity that's been given on to us. I'm very grateful. I want to say that when it comes to AI, right, its integration is very important, like I said continuously, and there's still space for further growth, especially in Africa, not just in the bringing in of technologies, but also in the workforce that we have here, because the workforce that we have that is educated on this, they are limited, and that's just going to cause a strain on them. And when there's a strain in healthcare workers, the next thing we are going to do is leave the country to where it is easier for us and where there's more appreciation. So there's a lot of work to be done on various levels, and we have a role to play apart from just the government. We have a role to play by educating ourselves and educating those around us. And I would like to end this by inviting anyone that is in Lagos to the World Health Exhibition that's occurring 2nd of June to 4th. So there are going to be a lot of people from outside the country that are going to come with their technologies that they have to introduce it to the Nigerian health sector in the prospect of finding buyers and raising awareness. So if you are interested after today, see you in Landmark, and you can always reach out to me. Thank you very much.
Guys, please connect with all our speakers on LinkedIn. I think that's a good place to connect. We hope that there will be opportunities for collaboration. There, like we said, there is a lot of work to be done. Chidi, do you have some words in closing for us?
Yes, thank you to Mozisha and Ken. I thank you for hosting this very inspiring conversation. I would say that in closing, what I am leaving this conversation with and I'm inspired by is the fact that Africans are talking about AI for Africans. I think in the conversation with AI, there's a certain face to it. There's a certain part of the world that it's associated with, but it affects all of us. And so I love that we can have conversations like this where we are centering ourselves and saying that we are part of the conversation too. And there's no reason why the tools and innovations and excitement of this technology doesn't also apply to sub-Saharan Africa. And even though I'm in the United States, my heart, born in Nigeria, my heart is always with the continent, with my people. And so I am excited to learn and train here because at the end of the day, I'm thinking about how these benefits can be applied to folks back at home, to my family in Nigeria.
Awesome. Thank you so much, Chid. It's great having you. Maureen?
Okay. Am I audible now?
Yes, you are.
Awesome. So I think, thank you so much, Dr. Kenny, for organizing this. Thank you so much, Dr. Chidi. Thank you, Faith. I think for me, it's just like what Dr. Chidi said, African solutions for African problems. We're the best people to solve our own problems. And I also just think we should not depend on aid to solve our problems. I just need to divert there just a bit, right? We have everything we need. We have everything. We have the people, we have the resources, we have the ability. And I think when it comes to AI, there's a lot of training that we need to do. And I think as we're speaking, I'm just thinking about, especially in the education space, we need to really repivot the structure of how we are delivering education to the people of today, to our young people. Otherwise, then we're failing a generation, and we will want that. Thank you.
Awesome. Thank you so much, Maureen, for that. Once again, thank you to all our panelists. This has been very, very insightful. Drawing from your real life experience, you've actually enriched the conversation. And thank you also to all our participants. Thank you for being part of this. This is just the beginning of the journey. The journey to transforming Africa's healthcare in the era of AI is just the beginning. And my hope is that one or two things must have inspired you that you took on or that you're going to take from here and begin to act on. In closing, there's a line that we normally say at Mozisha: AI handles what can be specified, human handles what has to be felt. We are human beings, not human doings. And our hope is that we go on from here, nourishing what really makes us stand out as human and helping to elevate one another. Once again, thank you, everyone. I appreciate you all and have a beautiful weekend ahead.
Thank you. Bye-bye.
Thank you. Thank you.
Okay, that has been a good one. Let me end the meeting.